Wow, thanks, Kim. It was quite an introduction. I know we're fashionably late today, so I think she probably did a good job of introducing me. I have presented on stigma a couple of times. I've been on both ends, right? I'm a person in long-term recovery and now working towards my master's in social work. So hopefully being able to see through the lens of both sides will help me, reach the population that I'm passionate about. So we are going to start by watching a video about stigma.
They transported me to Meriter ER.
I would say the ER experiences lined up with a lot of the stigmas at that point in time. Nurses, even doctors, I felt like I was being discriminated against. They wouldn't allow any medications or anything. I was just a junkie, and I was just gonna continue doing that. Even though I was 17, 18 years old, I wasn't even a person to anybody, is how it felt.
Stigma, for me, it was attached to a lot of shame, right? You're bad, you're wrong, you're incorrect.
And it really takes a toll on one's self-esteem, and even while interacting with teachers or people who are supposed to be either authority or role models in my life, when they have a negative attitude upon you as a child, it takes a toll.
They don't want to lie to you. They don't want to. They want to tell someone, but they're embarrassed. They have shame, and there's stigma. What can I do as an emergency physician? Say there's no place for that. I'm here for you. Just tell it to me straight. They're worried about people knowing they have an addiction. It's the stigma. The stigma's horrible, and the stigma's killing people.
We should be very careful how we look and talk about addiction, because there's a lot of stigma, a lot of negative attitudes and perceptions, and a lot of stereotyping, while in fact, addiction can affect anybody.
I think the biggest myth of addiction is simply that it's a moral failing, that people, for whatever reason, don't care and they're fine with being addicted to a substance, which is completely absurd. This is a brain disease. This is a real problem that people want help for.
Patients may be judged harshly or as drug-seeking, so it can be understandable that patients may not always want to be forthcoming about their struggles when it comes to substance use. And then, of course, as you might imagine, that becomes a vicious circle because patients feel compelled not to be completely truthful, and then healthcare providers identify those people as not being forthcoming about these issues and a challenge to deal with.
The faces of addiction that we see in the emergency department, I think we all have this picture in our head of what an addict looks like. It's somebody who lives in the inner city and they're homeless and they're dirty. But the truth is, it's everybody. I see young patients who are addicted to drugs. I see elderly patients who have heroin addictions.
Stigma plays, again, a huge role in driving the disease underground. I think addiction flourishes in the dark, and I think the stigma is one of the main things that keeps the lights off. If a patient comes in and they're taking pain medication, I don't necessarily. It's a little bit uncomfortable to broach a subject. Well, do you think maybe you've slipped from chronic pain into opioid use disorder? And that's a very, very fine line and very difficult to diagnose. And I think a lot of physicians really don't want to have to deal with that. There's this kind of misunderstanding that it's a fault, it's a character flaw, rather than it being a disease. If someone has diabetes, there's no stigma associated with using insulin. But for someone with opioid use disorder, a lot of times that was facilitated by doctors prescribing medications that maybe we shouldn't have been prescribing in a high of a dose. So we have to own the role that we had in this epidemic. But then there's this stigma associated with not wanting those patients in my office.
Relapse happens in addiction. It's a natural part of the disease. And yes, people go to emergency rooms repeatedly with episodes of addiction. So do they with asthma. And when they go into the ER with asthma, what does the ER do? Oh my goodness, you can't breathe. Let's do something to help you breathe. And if you come in with addiction, it's like, what are you doing here? How did your treatment fail? Why are you sucking money out of the system? Why are you a social reprobate? The amount of stigma, the amount of antipathy toward people with this disease is profound.
There's also the stigma, I think, very important to understand is that from the patient's perspective, but there's a stigma definitely associated that makes people hide it until their lives are destroyed. And the path to destruction, with alcohol, it may be decades, and with fentanyl or heroin can be one dose.
So the key element that we all need to promote is better access to addiction care and making sure that a person feels empowered to seek help. Stigma of addiction creates the barrier. Shame of addiction create also a barrier, preventing people from asking for help and accessing treatment. If we approach it in this way, individuals who are affected by addiction are usually much more forthcoming to discuss it, to ask for help. Promoting the scientific fact that it is a treatable disease rather than a moral failure will help people overcome those misperceptions, shame, and seek out help.
So I don't know which side of that equation you're on, but I want to preface by saying it doesn't matter, right? We're not here to say if you're stigmatizing, you're a bad person. We're all human, right? We all have thoughts. A lot of times they just naturally develop. But if you're on one side, I hope to hopefully plant a seed to maybe get you over there on the other side. So we're going to start by defining what stigma is. SAMHSA defines it as a mark of disgrace or infamy, a stain of reproach that's on one's reputation, social process in which people are labeled and set apart. So how does stigma develop? So, that's right. That's next. Not bad. Yeah. So we know stigma begins with stereotypes, right? We often start when we're very young. Maybe you adopt your parents' views or society's views. Then they kind of turn into possibly prejudice, where you've got a little bit of emotion behind it. And it can often lead to discrimination, where your actions, kind of those thoughts and those emotions, turn into actions where you're discriminating on someone. And then we also, bias plays a part. Implicit and explicit. Implicit is kind of unconscious, right? You don't even really think about it. But explicit is, you're very aware of it. But explicit is not good, but implicit can often get us in trouble because we're unaware of it, so we just kind of keep rolling with it. And so you see how all of these kind of play into stigma. Okay, what's next? Oh, the 3 levels of stigma. So we've got structural, public, and self. Structural is kind of those policies and procedures on an organizational level, maybe healthcare systems, schools, government. Next is social, which is obviously the disapproval of people based, like a group based on certain characteristics. And we know that social stigma can often turn into self-stigma. When those people kind of start believing what society is telling them that they are, right? Bad. You brought this on yourself. So people then start to believe that. And stigma is based off perceived fault and perceived control. So when people have conditions, usually such as maybe hypertension or cancer, we usually don't attach any stigma to them because it's not their fault, right? As opposed to substance misuse, the majority of people think it's their fault or it's a choice. So we often stigmatize them more often and kind of feel like they're in control of it. And I know there's a lot of healthcare people in here, and I'm sure you guys have seen it in your day-to-day, but even providers and healthcare workers aren't immune to stigmatizing attitudes, right? I can kind of even get it day in, day out, seeing, when we think of, when society thinks of substance misuse, you think of like crime, robbery, drug seeking, you think of all of the bad qualities. So I can get it, but we're not thinking of substance misuse as what it is, right? Which they said earlier was a chronic health condition. So depending on where you look is where you'll find the definition for a chronic health condition. But we do know that there's some similarities between the chronic health conditions. So a disease that is long in duration. So if you've known anybody who has struggled with substance misuse, it probably wasn't a couple of months, right? It's something that they struggled for with years and years and years. It's a disease that is associated with persistent, recurring health issues. Again, substance misuse checks that box, right? Mixed issues, usually involving some heritable component. We know, research has shown us that 40 to 60% of us are predisposed genetically to substance use disorder. So we know that plays a part in it as well. Have no definitive cure, right? There's one size does not fit all in substance misuse. It takes multiple things. What works for one person might not necessarily work for the next person. And then a disease that requires ongoing care, right? So you get sober and you're like, yes, I beat it. Right? That's not the case, right? You got to continue with your treatment, with your groups, your therapy, whatever it is that keeps you on the recovery journey. That's what you need to do. So a little bit of comparison. Hypertension and substance use disorder, you can kind of see they're similar, if not identical, in the stages of treatment. Before they start treatment, they're both pretty high in the severity of symptoms, right? But once you get them on some treatment, they kind of level out and they're doing good. But you take them off of that treatment and the severity of symptoms strike right back up. Same with relapse rates. They're all pretty similar with, and we'll talk about relapse a little bit more, but that's the similarities, and they go on, but those are the two that stand out. So hypothetically, what if we had a person A, who came into the ER with heart failure exacerbation, right? So they were told in the ED they're not going to get oxygen if they don't sign an agreement saying you won't eat any salty foods. Okay? Yikes. That's not my dad. What if the admitting doctor told them that it's their fault that they have heart failure? What if the staff said that they weren't going to get diuretics because that would only encourage them to eat unhealthy? Ooh, I'm seeing a lawsuit right about now. What if the hospital denied them an ICD because of their past behaviors? Not okay, right? I don't think one of you would be like, no big deal. That's not okay. So how about patient B comes in, right? They come to the ER with endocarditis, and it's because of IV drug use. They're told in the ED they can't get buprenorphine. Gotta sound it out, sorry, that's a toughie. To manage their withdrawal symptoms unless they sign an agreement. The doctor tells them it's their fault that this happens through drug use. They're not offered any kind of treatment because that's only going to encourage them to go back out and keep using. Sounds a little familiar. They're not offered any naloxone because, again, yeah, that would encourage them. What do you think the difference is between patient A and patient B? Stigma, right? I don't think that it's any surprise that it's stigma. That just wouldn't happen. So we've got to start seeing, well, thank you, didn't know where I was going. We got to start seeing substance misuse for what it is. And it's hard, again, I go back to, it's kind of hard because I kind of get why society feels the way they do. But why, we never think, we just see kind of, we accept society's version of truth, like, oh, yeah, they're a lost cause. Moving on. Do we ever like slow down and just kind of think, why? Why are they doing that? How did they get here? I mean, we're so busy, you know, we've got time, gotta keep going. But if we were to like slow down and just ask why or what can I do, you might be surprised. And so we know there's multiple factors, right, that contribute to substance misuse. You've got the risk factors. The more risk factors, the higher chance that you will develop substance use disorder. Then you've got the protective factors, loving family, those kind of cancel out all of the risk factors. And then the different vulnerabilities because of it. So risk factors can range from biological, psychological, and contextual. We already know that 40 to 60% of us are predisposed to having substance use disorder, right? But obviously that doesn't mean that we're going to develop it. But let's say, my bad. Okay. But let's say we have depression too. Let's say maybe we have a few ACEs from childhood. Maybe we were abused. Maybe we're bullied. Maybe I have a learning disorder, a reading, I'm dyslexic. Then you've got the contextual factors, which really start adding up. Your environment, your home, where you live, where you work, all those things, start adding up. So we're going to watch another little video, because I was going to try to explain it myself, but I'm not a physician, so I figured you like, who cares? But this is one of the best videos I've seen. It's very simple, but kind of like how the brain works in the science of addiction.
This is Susan. Susan loves to bike. While out for a ride, she falls and breaks her arm. Special cells called neurons send a signal through the spinal cord to the brain, which interprets the signal as pain. Susan understands the pain means she needs to go to the hospital, and her body is equipped for survival, helping her not to panic so she can seek help. Many of her neurons are covered in proteins called opioid receptors. These receptors act like a brake to slow down the neuron's ability to send pain signals. When injured, her body releases natural painkillers called endorphins. Like a key in a lock, endorphins activate opioid receptors, slowing down the pain signal and preventing a panic. Susan gets treated for the broken bone, but 3 months later, her arm still hurts. And now that pain is making her feel depressed and anxious. So her doctor prescribes an opioid painkiller. There are many different opioids, but they all share a chemical similarity to our own endorphins. This allows them to bind to the same opioid receptors and stop pain signals. But that's not all they do. Deep inside Susan's brain is a region called the ventral tegmental area, or VTA for short. The VTA is full of neurons that produce a chemical called dopamine. When something good happens, dopamine is released, giving Susan a feeling of pleasure. This helps teach her brain to keep seeking out good things. To keep dopamine neurons in check, inhibitory neurons keep the brakes on until something good comes along. Just like the pain neuron, these neurons are covered in opioid receptors. When Susan takes the painkiller prescribed by her doctor, the opioid receptors turn off the inhibitory neurons and release the brake on the dopamine neurons. The rush of dopamine temporarily eliminates Susan's depression and anxiety, and she feels relief, calmness, and even euphoria. As Susan continues to take the painkillers, her brain responds by trying to regain its balance. Her inhibitory neurons work extra hard even when the opioid receptors are activated, and it becomes harder and harder for her dopamine neurons to release dopamine. Susan finds that she needs to increase her dose of painkillers in order to feel comfortable. This is called tolerance. Eventually, Susan's pills run out. Inhibitory neurons that had been working overtime are let loose, clamping down on those dopamine neurons and shutting them off almost completely. Now, not only is Susan in pain, but the depression and anxiety come back. On top of that, Susan feels ravaged by an inescapable physical sickness far worse than any flu. Susan's body is going through withdrawal. Most people who take opioids for a long time tend to experience some withdrawal, but they can still stop taking the pills and return to normal. But for people like Susan, it's not so easy. Her genetics and the environment she grew up in put her at a higher risk for addiction. Her withdrawal symptoms aren't just unpleasant, they're unbearable. Susan thinks the only way to feel normal is to find more opioids. And this is how the cycle of opioid addiction emerges, driven by a brain trying to regain its balance. But there is hope for Susan. Though the road to recovery can be challenging and there may be setbacks, treatment can retrain Susan's brain. With the help of medication and therapy, Susan finds pleasure in her life once again.
So Dr. Martin probably explained a little bit better, but basically, we've got these neurotransmitters, right? And I don't know all the terminology, so correct me if I'm wrong or interject at any minute, Dr. Martin, but we have these neurotransmitters that help us and encourage us to do healthy behaviors, like the reward system, right? Eating, seeing your child play, all of these things are rewards us. Well, when you use a substance, sometimes they mimic what these transmitters do, right? And so they kind of do the same thing that they do. Am I right so far? Okay. I had like a whole slide. I wish I would have kept it now. But then I found this video. So, anyway, so over time, you have the dopamine, which you get an influx of when you're using a substance. So as time goes on, your brain literally reprograms. So the choices that you made when you very first started using, or even before you started using, your decision-making skills, your judgment, it starts to get off kilter. That's what I got. Great. Yeah. And I love that I'm in front of healthcare people. They're like, yeah, you're doing great. Okay. So we know all about stigma, why it happens, but what can we do to stop it? I'm glad you asked. There's a few things that we can do. The most effective way to combat stigma is to normalize it, right? 1 in 5 of us struggle with a mental health illness. 1 in 7 either has or has had a substance use disorder. That's a pretty good chunk of us, right? So chances are, if you're not one of those people, you know someone that does struggle with that. And there's a good chance that you're probably close with someone who struggles with that. So putting a face to someone's lived experience is key to combating stigma. Examine your own biases, right? I mean, again, I said we're all human. We all have thoughts, and that's okay. But take the time to really listen to yourself and examine your thoughts. It's okay if you have bad thoughts, or it's okay if you have certain beliefs or attitudes. Once you realize it, the good news is you can kind of start correcting yourself, right? Educating yourself. Show compassion. I gave the example of everybody is just in a rush, right? We're too busy to slow down. But if you just show compassion to somebody, if you slow down, take the minute to slow down and ask, you'd be surprised how many people would finally ask for help. They're like, this is the first time anyone's asked me. I mean, they struggled with addiction for 15 years and no one's even bothered to ask them, like, can I help you? Like, wow, you know? Show compassion, support and include. Kind of goes with compassion. And another way to like support people is kind of going back to the structural stigma. Look at certain policies and procedures that are maybe in your organization, your faith-based community, your social club. Check to see if it's like this outdated language that kind of perpetuates the cycle of stigma. And if it is, advocate for the change. Be the one who challenges the stereotypes, right? Learn the facts. So the best thing you can do is to educate yourself. Learn about the science of addiction. Learn about treatment. Take the time to understand the processes and then take what you've learned and then share the wealth. Go and spread the good word, right? And then one of the last things that we can do is change our words, right? I'm sure you guys have seen some of the certain campaigns. Can you click the next one for me? Oh, there it is. Words matter, folks, right? I mean, the old saying, sticks and stones may break my bones, but words can never hurt me. Yeah, that's just not true, right? We can pretend that they don't, but they do. So just watching how we say it, and I'm guilty of this, right? I struggled with addiction more years than I did not. So in my head, an ex-addict. I struggle with that too, right? I have to train myself to say I'm a person in long-term recovery instead of ex-addict. So just some examples, person with substance use disorder. Hopefully y'all know by now, junkie that's outdated. That's something we probably don't want to use. Definitely not in the hallways while we're treating them, right? Because they can hear that. Again, ex-addict, former addict, person in recovery. How about, even if they're talking out their mind, how about, I hear what you're saying, instead of like, it's all in your head. You know, like, eye contact, I hear you, I'm not crazy, but I hear you, you know? It is not a drug habit, it's a disease. And I get it. At one time, someone did have to make that choice. You're absolutely right. They had to choose to take that drink. They had to choose to take that substance. But again, why? Why did they do that? And why did they continue? What were they escaping from? Like, why the continuation of it? Because I can promise you they were like, you know what? I'm going to be an addict. Like, I've never in my life heard one person say that. That's not what they want. That's not what they want. So they must not really want it. If they wanted treatment, they'd be in it. Do y'all know how many barriers there are? I mean, stigma alone, which is the biggest barrier, but so many barriers for people to try to access treatment.